Module 11. Respiration and the chest. Breathing over hours, the medical causes, the traumatic ones, and the interventions that need maintaining once they exist. One respiratory rate tells you almost nothing. A series tells you nearly everything. Counts without announcing it. A watched casualty breathes differently. Notes the effort, whether they can speak in sentences, and compare with the last written entry. Day 1 and Day 2 are different chests. What was pain and splinting yesterday can be pneumonia or a growing pneumothorax today. Two medical causes with different shapes. Pneumonia builds, fever, cough, worsening oxygenation past Day 1. Embolism strikes, sudden distress in an immobile casualty, often with a quiet chest. Neither is diagnosed from one number. Both get the same response frame, recognise, support, antibiotics, per Module 17, where pneumonia is the read, consult and move the casualty back. Pneumothorax is first a ventilation problem. Hemothorax is a breathing problem and a circulation problem at once. The blood in the chest came out of the circulation. Both can evolve during the hold, so the injured chest is re-examined whenever breathing or circulation changes, not just at the first survey. The schematic shows why tension kills. Air under pressure on the injured side, the mediastinum pushed across and the return to the heart falling. The casualty is not dying of the lung, they are dying of the obstructed circulation. That is why the treatment is a needle and why it cannot wait for certainty. Tension pneumothorax is a clinical diagnosis. The picture: an injured chest, progressive respiratory distress, and shock or rapid deterioration. The textbook signs, tracheal deviation, distended neck veins, are late, unreliable, and mostly invisible in the field. Two more honest facts: a sealed chest can still tension, and tension can develop at hour 3. Certainty is not required before decompression. The picture is. Two approved sites for needle decompression of a tension pneumothorax: the 5th intercostal space at the anterior axillary line and the 2nd intercostal space at the midclavicular line on the injured side. Always over the top of the rib, the vessels and nerve run under the rib below. If the first site fails, use the other. Protocol skill: locked equipment, 10 or 14 gauge, 3 1/4 inches, 8 centimeters. Insert and then judge by the casualty, not the sound. The hiss is theatre, the clinical response is the answer. Reassess immediately, breathing, shock picture, and chart the decompression. Site, time, response. Note that the catheter can kink, block, dislodge, or never have reached the pleura. Even a working needle is a bridge, not a repair. So the decompressed chest joins the round. Watch for retention, be ready to needle again at the other site, and know the definitive answer is a drain, which is provider level work. If a chest drain or tube thoracostomy is placed, it may have a simple valve, a drain setup, or a bag at the end. The setup drawn here shows the drain exiting the chest, tubing to a bottle kept below chest level, the water seal, and the swing at the fluid level that tells you it is communicating. Bottle below the chest, connections checked. Those two rules prevent most drain disasters. To repeat, finger thoracostomy and chest drains are provider level. Your job here is to recognize, assist, and maintain. Maintenance is the long part. Every round, bottle below the chest, swing and drainage watched and written, connections checked, the site inspected. A drain that stops swinging or comes out goes straight to the consult, not to improvisation. A chest seal may also fail. A seal can lift, fill with blood, trap pressure, or hide continued bleeding underneath. Inspect it every round and after every move. Deterioration in a sealed chest means burp the seal, and wet edges get resealed on a dried, cleaned margin. The failures here are failures of reassessment. A Day 2 breathing change written off as pain without a fresh chest examination. A sealed chest assumed safe. And the decompressed casualty treated as fixed while the needle quietly kinks. From this module. Breathing is trended, not collected. Tension is treated from the picture. Injured chest, distress, shock. With the locked needle at either approved site, over the rib. And every chest intervention becomes a round item the moment it exists. Sources on screen. Module 12. Circulation, Shock, and TXA.